Please be aware that this session is being recorded. I'm Karen Crowley. Jonah Bradenday and I work in BCBI, the Brown Center for Biomedical Informatics. We're pleased to join Brown's celebration of Love Data Week by presenting Need Health Data, a data request primer. I'm a biomedical informatician and manager of health data science here at BCBI. And I have a great interest in leveraging data to support and improve clinical care and the health of individuals and populations. Through the Unified Research Data Sharing and Access, or URSA initiative, BCBI and our service arm, the Advanced RI-CTR Biomedical Informatics, Bioinformatics, and Cyberinfrastructure Enhancement, or BIBC core. We have lots of acronyms here. We have partnered with several Rhode Island health institutions to provide data to researchers. These institutions include Lifespan, Care New England, the Rhode Island Quality Institute, and the Rhode Island Department of Health. Each of these health data partners have unique administrative processes for requesting their data, as well as strict guidelines for working with the data and sharing results. Members of BCBI and the BIBC Corps serve as liaisons between researchers and our health data partners to create and submit accurate and complete data requests, as well as oversee the governance of health data transferred to and utilized at Brown University. BCBI and the BIBC Corps also guide researchers through the process of accessing national data repositories provided for use by the National COVID Cohort Collaborative, N3C, and the All of Us Research Program. As an introduction to data requests, let's take a quick look at one part of the research process. With an idea in mind, we conduct a literature review to refine that idea and generate a research hypothesis. Then we can proceed to define our research cohort or cohorts. And information gathered and decisions made through these steps are integral to our data request or data extraction specification. A good data request will include a data extraction specification that is clear, specific, and computable. It will include a cohort definition, a list of the data elements requested for each person in the cohort, and the code sets required to identify the cohort and extract the data. Even in the case when you or a member of your research team is programming the data extraction, a detailed extraction specification is key to unambiguous communication and reproducible research. The data sets we might request for our research fall into four main types: aggregate statistics, de-identified, limited, and identified data sets. We might begin with aggregate statistics to assess the feasibility of conducting our study with the data source we have chosen. If the numbers are favorable, we'll proceed with a de-identified or limited data set. These data sets differ in the number of PHI, or personal health information elements, that are removed, and how dates and geographical identifiers are handled. Identified data sets in which persons are clearly identified are generally only needed for patient care or clinical registries. There are many kinds of real-world health data. Data collected during our encounters with healthcare providers and organizations, data used for filing and paying claims, from genomic data to environmental data, from data we generate and collect about ourselves to our family histories to characterizations of the communities and populations to which we belong. Real-world data, through the process of rigorous analysis, can become real-world evidence that can guide us in improving the health and lives of real persons and populations. Let me emphasize real persons. When designing our studies and requesting or extracting data, we should limit those data to the minimum necessary. And we must do all we can to protect confidentiality and minimize the opportunity for re-identification. So I will hand the presentation over to Jonah to go into more detail about data extraction specifications.
Hi, I'm Jonah Bradenday. I'm the Health Applications Analyst at BCBI. And among other roles, I'm on the other end of the URSA Services and Support ticketing system. So if you have any questions about anything that we discussed today, please reach out to us at ursa-help@brown.edu, and I or someone else on my team will get back to you. We created the URSA data request form to help facilitate data requests between Brown researchers and some of our health data partners in the area. But this form can also be used to communicate analysis instructions to programmers or to generate your own data extract internally. And before I dive into the actual request form, I want to discuss a couple guidelines. The first is that your PI and a subject matter expert should review all sections of your completed data request form before you submit it to your health data partner. And the other is just that the advanced RI-CTR-BIBSI core is available to assist with all stages of the data request process, whether that be the actual form itself, so the different sections of the form, which we recommend reaching out to us for help about, or the data request process as a whole, communicating with the health data partner, submitting the request form, all of that. And again, our contact is our ticketing system, ursa-help@brown.edu. The request form itself is very simple. It's built using Google Sheets with each tab representing a different section of the form. The first section, version, this exists so that your team, my team, and the health data partner can keep track of the different edits that your team does to the form before submitting it. So for each version, you're going to include a version number, the date that you made those edits, your name, and then just a brief description of the edits. The next section is information. Here you'll provide details about yourself, about your PI, details about your project, so your project title, a description of your project, how your project's being funded, confirmation of approvals and requirements, so IRB requirements, data use agreement requirements, and also details about the actual extract. So will the extract be a de-identified data set? Will it contain PHI? Where is the extract being generated? Where's the data coming from? Where are you going to actually work on the data extract, run your analyses? And if a transfer is taking place between that the data source and the destination for the data, how is that transfer taking place? And for this section especially, we recommend that you work with the advanced RI-CTR-BIBSI core, us, as we have a lot of information, especially for some of these later items that could help you fill out this section. The next section, cohort definition. This is where you're describing who/what group of people you want included in your data extract. That's your cohort. And that's exactly what you're putting in your cohort description, a brief, human-readable description of your patient population. So in our example, we described our cohort as patients who are greater than or equal to 18 years old with at least one diagnosis of type 2 diabetes, no diagnosis of type 1 diabetes, no diagnosis of secondary diabetes, with at least one DPP-4 inhibitor on the medication list. There's a lot of information there, but none of it's redundant. Below the cohort description, go your inclusion criteria. In these, you're dividing your cohort description into simple computable bits of criteria. So that first section in your cohort description, patients who are greater than or equal to 18 years old, that's an age criteria. So I put that in inclusion criteria age. And then there's no mention of sex, setting, time frame, or race ethnicity in my cohort description. So I marked all of those as all, meaning I want to include all sexes, all settings, all time frames, and all races and all ethnicities in my data extract. And then type 2 diabetes, type 1 diabetes, and secondary diabetes, those are all diagnoses. So I added those to the diagnoses inclusion criteria with their respective inclusion or exclusion rules. And then lastly, a DPP-4 inhibitor, that's a medication. So I added that to the medication inclusion criteria section. Also on the cohort definition tab is the optional control section. This section exists in case your study needs to compare a population of control patients with the case patients that you described in your cohort description and inclusion criteria. And just like your cohort description, you provide a controls description. So in our example, patients who are greater than or equal to 18 years old with at least one diagnosis of type 2 diabetes, no diagnosis of type 1 diabetes, no diagnosis of secondary diabetes, with no DPP-4 inhibitor on the medication list. The only thing different there is the no DPP-4 inhibitor as compared to the with one DPP-4 inhibitor in my cohort group. This is just the opposite. So it's the same diabetes group, but without the medication that's listed in the cohort case group. Below the description, you note the variables you want to match your controls against your cases with, what features you want them to share. So in our example, we chose to have our controls and cases matched on age, race, and gender. And then below that, just make sure to note the ratios that you want to include of control patients to case patients. So in our example, it says 2 controls for every 1 case for our data extract. Next comes the code list cohort tab. In health databases, clinical concepts from diagnoses to lab results are represented by health terminology codes. That means every single clinical concept that you've mentioned in your cohort description and inclusion criteria needs to be defined on this page using those health terminology codes. And each one of those concepts may have multiple associated health terminology codes. So if you look at our example here, at the top, I have a list of 5 DPP-4 inhibitor codes. Each one of those codes pertains to DPP-4 inhibitor. And then below that, I have some type 2 diabetes codes. Below that, I have type 1 diabetes codes, and then a secondary diabetes code at the bottom. And again, if I mention a concept in my cohort definition and inclusion criteria, I have to define it using health terminology codes on this tab. And for each one of the codes, I list the category on the left. So medication is a category. Diagnosis could be a category or procedure. Code system, that first one is an RX norm OMOP concept ID. Next, the code itself, that numeric code right there. And then on the right, just a brief description, and that description should match the description used in your cohort definition and inclusion criteria. So I said DPP-4 inhibitor in that first tab, I'll say DPP-4 inhibitor here. And then this is where I'll also mention that we have another session, another tutorial today at 1 p.m., Need Health Data Codes, where we'll discuss some of the resources available for finding these types of health terminology codes and pre-gathered and categorized code groupings. So if you're planning on filling out a data request form, or if you just want to know more about finding codes, I suggest you attend that session as well. The last tab in the IRSA data request form is the fields extract tab. In the previous sections, you were describing who you want to include in your data extract, which population. In this tab, you're describing what data you need. So for each patient in your cohort, which fields do you actually want to see in the files that you receive from your health data partner? When you're running your analysis, what variables do you want included? Your health data partner is going to use this section to actually build the structure of those files. So you should make sure to note every single field you want here if you want to see it later during your analysis. Depending on the structure of your health data partner's repositories, the fields available to you may differ, though the process for filling it out should be the same. For example, the one we're looking at here, the fields extract tab we're looking at here, is in the OMOP common data model. Some of our health data partners use the OMOP common data model, others don't. For instance, lifespan hospitals don't use OMOP. So the fields available will be different if you're requesting data from lifespan, but the process should be the exact same. And my team has pre-filled a most of the or a lot of the more commonly requested fields for different structures of repositories, so for OMOP or other structures. But if you need to request a field that hasn't been listed, that's not there, you can, of course, add it at the bottom. Something to keep in mind when requesting fields that aren't pre-filled is you shouldn't request something like, does this patient have cancer? Yes, no. Instead, you'd request all of the diagnoses for a patient, because cancer is a diagnosis. And then once you receive the files and you have that diagnosis list, you would then clean and stage the raw data and answer the question for yourself, does this patient have cancer? Yes, no. For each field that you're requesting, whether it be one of our pre-filled fields or a custom field, you're going to mark include in the include column, and then you're going to mark a priority. Priority exists in case the health data partner decides that maybe due to risk of re-identification, that they're unable to include every single field that you requested. By marking some as high and some as low, they know which fields to drop, if any need to be dropped. And you'll also see that I said in the notes column on the right that all CSV files should contain person ID for matching. This is just to ensure that when I receive these files, these CSV files from my health data partner, there's a common variable between all the files so that I can match patients and the files aren't isolated from one another. And this variable doesn't have to be patient ID. It could be some other variable. It could be encounter ID. But you should make sure to note that matching variable in this tab. These are also just some of the other OMOP tables and fields available in this version of the Fields Extract tab. And I'll note that in the drug exposure tables and fields, I marked include all of these fields. So drug exposure ID, drug concept ID, drug exposure start date. Just because I'm marking, or just because I mentioned patients needing a DPP-4 inhibitor, that medication, in my cohort description, that doesn't mean that I only want to receive DPP-4 records in the extract. I want my medication list to include all medications because I marked these fields in the drug exposure table, not just the medication that I mentioned in my cohort definition. That's for identifying the patient population. This section is for identifying what data I want from those patients. So you might have a DPP-4 inhibitor as well as many other drugs in your medication list. And that's it. We still definitely have plenty of time for questions. I just want to mention quickly a couple of things that I've already said, but if you have any questions about the stuff that we talked about today, or if you want to start using some of these resources, reach out to our ticketing system at ursa-help@brown.edu. And I or someone else on my team will get back to you. And the other is just a reminder about our second session later today at 1, called Need Health Data Codes, an Introduction to Health Terminologies. You can register for that on the Love Data Week library website. And we'll discuss some of the resources available for finding those health terminology codes and the code groupings. Thank you. Do you have any questions?
Jonah, do you want to stop the screen share so we can see everybody, please? Awesome.
Well, I'm glad everything was so clear.
Okay.
Like most things, they seem very clear when you're listening to a presentation, and then when you go to fill out a data request form, you start second guessing yourself or asking all sorts of questions. That's why Jonah and I and the rest of our team are here. Definitely contact us through ursa-help@brown.edu. we're happy to help you with a good data request, as well as shepherd you through the process of getting data from our health data partners.
Thank you both. Oh, we had somebody say, okay, thank you.
All right, it was a pleasure. Thank you so much for having us today.